This is a partial panorex of an impacted number 32 with associated hard tissue neoplasm on a 17-year-old white male. He was referred to me by his general dentist for evaluation and surgical management of the situation. Patient arrived with his mom. He was having no symptoms. He didn't even know he had anything going on, which is not an unusual incidental finding on panorex. And when the patient saw his CT scan, I explained to him what was going on, that there was some type of neoplasm, likely a cyst, although I don't like to use the word cyst without having a definitive diagnosis, that had caused some mass effect and pressed on the bone and causing the bone to dissolve around this impacted wisdom tooth. I also explained to the mom and the patient that the wisdom tooth, the roots of the wisdom tooth, were very near a nerve and a nerve canal that created some complexity in our discussion. So when I approached this, I tried to give them multiple options about which way to go with potential treatment. The first thing would be to do nothing. That is always an option, although I did explain the risk of not doing anything at this time, that this was going to get bigger, it was likely to get infected, he was going to have swelling, pain, and damage to adjacent bone, and potentially teeth, and even the neurovascular structure. That was off the table pretty quick for he and his mom. Then I talked about removing the tooth along with the hard tissue neoplasm, but explained to them that there was a significant risk of nerve injury, and if that nerve was damaged, he could have permanent numbness in his lip and chin, and therefore the patient elected not to do that. He was concerned about that, as I would be as well as a patient. So we took that off the table and we went to coronectomy. So I explained that if we didn't take the tooth out, we could do a coronectomy on number 32, leave the roots behind, and take out the hard tissue neoplasm, whatever that may be. The problem that they had with that approach was the fact that if the roots were mobile at the time of the coronectomy, I explained to them that I would not be able to leave them in place. Loose roots would potentially cause infection, and we couldn't do that. So if I got mobile roots, I would have to take them out, and again, we would face potential nerve injury, and they didn't want to do that. So finally, I said, well, we can just take out the hard tissue neoplasm and leave the tooth alone, and we can keep an eye on it, and if we have problems later, we can address it, whether that be coronectomy or removal, understanding the future risk of nerve injury. And that's the choice they made. They wanted to just take out the hard tissue neoplasm, see if that will heal, see if a bone will fill back in, soft tissue will cover that, and we just have an impacted third molar that we just leave alone and we let it sleep. Now, I will say there's one options. I presented this to a couple oral surgery colleagues, and they talked about potential marsupialization to shrink that neoplasm to make it a little smaller and then enucleate. That's a good choice as well, a good option. I didn't present that to the patient, but that is an additional options that we could have talked about, and I've done that and successfully. But what we ended up doing was going with the removal of the hard tissue neoplasm, and I took the patient, put him under general anesthetic, went ahead and did a fine needle aspirate and seeing if we had any AV malformation, which we did not. We'd had straw-colored fluid, so it presented pretty quickly clinically as a cystic type entity. Made an incision, full thickness mucoperiosteal flap. I went in and opened up a little bit of window. There was a very thin layer of bone over the top of this on the buccal aspect of the area. This window, as I increased in size, I was able to bluntly dissect using curettes the soft tissue lining, or the cystic type lining that it appeared to be cystic, and this thing shelled out and enucleated. It was able to be enucleated pretty easily in one piece. And once we got it all cleaned up, I took a look. This tooth was super low in the mandible, very inferiorly positioned, and was going to be a problem to do a coronectomy on. So I'm glad we didn't elect to do a coronectomy, and we just left it where it was at. The pathology came back. It was diagnosed, and the pathologist eyes as a radicular cyst, which surprised me a little bit because I figured it would be a dentigerous cyst, as most of these are. But when talking with these oral surgery colleagues, we got to talking about the pathology and the definitive diagnosis, and they said it could have been an inflammatory process associated with it that made it look like a radicular cyst on review. And I use oral pathologists, I use general pathologists and not oral pathologists, and so they might not have known the details of the difference between the two. But anyway, it came back as a cystic lesion, epithelium lined, and we enucleated the thing in its entirety, and the patient came back a week later, very little swelling, very little pain, did very well post-operatively, and we're going to follow him, see him in a month and see where we're at, and then we'll go forward and do x-rays and exam probably at 6 months and see where we're at based on his recovery and the x-rays and potential symptoms that he may have. And I just want to share that case with you because I thought it was interesting, because it threw a little bit of a curveball at me, because usually you'll take out an impacted tooth with the neoplasm, but because of the potential nerve injury, presented a little different decision-making process for me, and presenting to the patient and the patient's parents and allowing the patient to make the decision. I think it was a good choice, and I was very comfortable doing it at this point, and we'll see how it plays out in the long run. And I wanted to share that one with you. If you have any questions about it or any comments, let me know. Thanks. This is the partial panorex of a 17-year-old white male. He was referred to me by his general dentist